So this is Tandega Dlamini today on February 19th, 2026 at Seattle, conducting an interview for the Global Oral History of PEPFAR project. So to begin with, could you start by introducing yourself, telling us briefly about yourself and family, where and when you were born, and where did you go to school?
All right, my name is Caroline Ryan, and I was born in Saskatoon, Saskatchewan, Canada. My parents were Irish, and my father was a doctor, and he came over to do his internship in Canada, and then he transferred to New York City to Cornell, New York Hospital. And then I was in New York City until my father went to Manchester, England to do research on cervical cancer. So I did my elementary school in England, and then I came back to New York. My father returned to Cornell in New York City. I did my high school in New York City at a girls' school called Chapin, and then I went to Smith College for 2 years, and then I transferred to McGill University in Montreal, Canada, where I got my BSc, and then I stayed for my degree in medicine. And after that, I did my residency in internal medicine at Yale in New Haven, Connecticut. And then I was an EIS officer, Epidemiology Intelligence Officer at CDC for 2 years. And after that, I did my fellowship here in Seattle at the University of Washington, where I also got my master's in public health.
Impressive. You've been around. It was a premonition of your career in the future, going around the globe and doing a lot of work. Okay, thank you. So could you just tell us about how did your career path start?
So my career path in HIV started actually when I was an intern at Yale New Haven Hospital in Connecticut. I actually was an intern for the first HIV patient in Connecticut in 1981. And then after that, my interest was in EIS and then in infectious diseases. And when I was here at the University of Washington, I actually, for 12 years, had a HIV clinic here in Seattle. So a lot of our work as fellowship fellows was to look after HIV positive patients in the hospital. This was before ART. So we were looking at patients, mostly gay men, who had pneumocystis pneumonia or CMV retinitis or Kaposi sarcoma. And then eventually, while we had the clinic, we were also able to start ARVs and see the transition from not having ARVs and treating opportunistic infections. And I think I learned a lot from that, because in those days you really had an idea of what was the stigma associated with having HIV. Our initial clinic, we couldn't have it in the hospital because people were too stigmatized to go to the hospital for care. So we actually had it in a storefront on Madison Avenue and just called it the Madison Clinic, so people would come. But at that time, it really was the first time infectious diseases didn't give people a cure. You really were dealing with a disease that had a lot of fear associated with it. And we ended up working as teams. So it was, each patient had a clinician like myself and a social worker, and we ended up being sort of the team that worked with the client, and we ended up sort of as family for the period of time until they passed. So it was a very at time, fearful and depressing, because you couldn't offer. But when the ARVs came, it was such a dramatic moment for hope, because you really could see the transition from very serious opportunistic infections where people truly suffered to people now having hope, and that was really encouraging. And I think that really stemmed my interest in HIV.
Thank you for that background. Could you just explain to me when you were doing the fellowship, like transitioning from medical training to now want to do MPH, what precipitated for you to want to do that?
So I did my MP. So when I was working here as a fellow, I was actually in the laboratory for my research was on cloning the erythromycin genes for Campylobacter jejuni, which is a diarrheal pathogen. So I was very lab-based, microbiology-based. And then in 1991, I sort of transitioned to work with a very renowned clinician here and scientist here at the University of Washington, Dr. King Holmes, who was head of the Center for HIV and STDs here at the university. And there was a project that the University of Washington had become a partner with a USAID-funded project. It was before PEPFAR. It was called AIDS Cap. And in AIDS Cap, they were looking at mostly prevention internationally. So they were looking at behavior change communication, condom distribution, and STD treatment, because at that point in time, STD interventions was something you could do. You could treat an STD because STDs increased the acquisition of HIV and also the spread of HIV, because you secreted more virus when you had an STD. And ulcers were worse than just having a discharge. And also people did health-seeking behavior for STDs. So if you had an STD, you were more likely to seek help. The other thing was STDs were more frequent in the populations at that point in time that were more at risk for sexually transmitted HIV, such as sex workers, truckers, and other, key populations. So because of my microbiology background and because of my clinical work, I worked for Dr. Holmes in that project, the AIDS Cap project. And as a result of that, we worked in several countries. We worked in Morocco, we worked in Cambodia, we worked in Senegal, we worked in Mali, and the Dominican Republic, and Kenya. So, so what we would do is we would, it was very hard at that point in time to go to a country and to treat STDs because you didn't always have the laboratory and you didn't always know what were the antibiotics to which the STDs were susceptible, because there was a lot of resistance, especially in gonorrhea. So what we would do is we would go to a country and we would find the at-risk populations, mostly sex workers, and truckers or men that were clients of sex workers. They were sort of the bridging population to their wives and to the general population. And we would, first of all, figure out what were the STDs and what were the susceptibilities of those STDs, and could we then establish what were called syndromic approaches, so that any rural health clinic or even at some point pharmacies could just give the appropriate antibiotics for the STDs that people were seeking care for. A lot of the work I did was with sex workers. So we would go to, for example, Mali. I worked in Mali for a long time. And what we would do is I didn't live in Mali, but we would go there frequently. And we would go and work with the sex workers in the different cities. And we would test them for STDs and HIV. And many of those women were not from Mali. So initially, the women, a lot of the women were from Ghana. And they would come and they would do sort of a rotation around West Africa. And they would go from sort of city to city in the different countries, because you're more commercially viable the newer you are in a community. So there was a lot of rotation. But they didn't have any access to care because they really weren't from those communities. So, it was a lot to learn because they didn't want to go to clinics. And so, knowing the women and talking to the women, what they wanted was someone to come to them. So we started brothel-based care. So I would get a taxi in the morning and take my examination table and put it on the roof of the taxi, and then I would just travel to the different brothels and treat the women. And a lot of the women wanted to know their HIV status because if they were going to be sick and die, they wanted to go home. And they wanted to see their children and their families. So that was, and also a lot of them were sick. They had tuberculosis, so we were identifying their STDs, identifying their TB, putting them on medication, and we actually started funds to help them get bus fares to go back home. So, and then it also was to try to figure out who are the clients. So in many of the populations, sort of like in Kenya or in other places, because of the rural to urban migration, a lot of men had migrated to the cities for work. And so what they would spend is part of their time in the cities and they were clients of sex workers, but then go home to their cities and have sex with their wives. And that was part of the transition or the transmission network that we were trying to intervene in. So, I did that work until 1997, and I got my MPH while I was working on that because I realized a lot of what I was doing was public health, and I didn't have an MPH, but I wanted to be able to do a lot of sort of the modeling and the statistics that I had not learned as a clinician. So I got my MPH then.
That was such a very, very daring approach. Putting your table on the top of the taxi and going there and moving brothel to brothel without a car and all of that.
But you know, that's what the women wanted, and our role was really to go to where they needed us. It wasn't for them to come to us. And I have to say, I had, brothel owners were very good friends. They wanted us to come. They wanted their clients to be well. They didn't want to be known as the brothel that spread HIV or the brothel that spread STDs. The other thing that we did was, like in Cambodia, we did the first comprehensive study of HIV in Cambodia. So I went there with 2 other women from University of Washington, and the 3 of us, we went to sex workers, antenatal care clinics, and to the military in 3 main cities. And this was in 1995. So in the north, actually, I have a great picture of me with the army that was fighting the Khmer Rouge. And we were trying to figure out what were the STDs and the HIV. So there was HIV in Cambodia, but the Khmer were blaming the Thais. They were blaming the troops that had come from Africa for the UN that were helping after the war with the Khmer Rouge. And so we went there and we found out what the prevalence of HIV was. It was quite high. And we also did the genetic markers to see what was what type of HIV it was. It turned out to be E and genetically similar to Thailand. So that stopped that whole blaming of the UN and the African troops, and we were able to say, look, it spread from your neighbor Thailand, and that really helped the government of Cambodia realize, okay, we need to deal with this and stop this sort of blame game and trying to get, reparations for what had happened when when the troops came in. And also we realized at that point in time that the gonorrhea was resistant to ciprofloxacin. And WHO was about to send a large amount of ciprofloxacin into Cambodia to treat the STDs, but after that we said, don't spend your money on that drugs, let's get different drugs to treat the women. And then also we realized, that there needed to be programs for the different populations, because after the war people were more concerned about landmines and they weren't really focusing on HIV. So it was an opportunity to redirect some of the health care from dealing with only landmines to dealing with the growing HIV infection. And the government of Cambodia did a great job. They really rallied around it and were very proactive in setting up prevention and treatment programs.
So who was funding this work that you were doing in Africa,
So it
Mali,
was, yeah,
Cambodia, and all of that?
So this program, AIDS-CAP, was funded by USAID. So, you know, we were the STD partners along with the University of North Carolina and the Institute of Tropical Medicine in Antwerp. There were multiple partners. We were not the behavior change communication or the condom distribution, but when we went into these countries, we went as a team. So I would go, and there would be someone who was a condom social marketer, and there would be someone who was a behavior change expert, and the three of us would work together to try to set up comprehensive programs for these key populations and really convince the governments. There was a lot of discussion at that point in time that governments didn't want to spend their money on these key populations. I want to spend it on general populations, you know. But we were showing them that, you know, this is the cost-effective way to deal with it. You have a concentrated epidemic in a population that you can reach before it gets to these other populations. So don't spend all your money on A and C clinics at this point in time. Spend your money on trying to contain a concentrated epidemic. So I think that that was useful too, because it was very politically sensitive working with some and putting the resources into these populations. But I think once people understood the dynamics of transmission and just cost effectiveness of early intervention in key groups, I think that was very helpful for their planning.
So you keep mentioning partners like for social marketing and behavior change and communication. That's quite interesting. Do you mind just saying, like, letting me know which organizations these were, or even people?
Sure.
Because I think it would be important also to add that narrative.
Yeah.
Let's
So
talk
there were
about pre-PEPFAR effort, you know, before there was art.
Yeah. So the overall AIDS-CAP project was managed by FHI. Family Health International, and the three different areas had multiple different partners working, because we were only working in about 7 countries, but there were multiple countries, you know, all these partners were working in. So the condom distribution program, the partner that I worked with mostly was PSI, and then for behavior change communications, it was Hopkins and other different groups. But there were multiple different groups. It just happened to be sort of the team that I was on. But I learned a lot, you know, like for social marketing, we were setting up things such as kits for STD control in pharmacies. So if a man went to a pharmacy and said, I have a discharge, the pharmacist would have a set little, oh, here's your package for a discharge, and it would have the right drugs in it, you know. So it was a way to, you know, make services available where they were needed and with the right type of services. And the behavior change communication, you know, that was a much more complex discussion with multiple different audiences, not only the key populations, but also overall dealing with the general sort of stigma, fear, and the benefits of accessing care and accessing testing.
And so you did mention the social marketing organization mostly.
PSI.
PSI still. So
Yeah.
condom distribution and
social marketing
was
yeah.
PSI.
There were others, but that was the group I worked
main.
with. Yeah.
Okay, gotcha. Thank you so much. So could you remember the first time you heard about PEPFAR and in your trajectory, in your
Right.
career? So
Sure.
when are you hearing about PEPFAR and all
Yeah.
of this?
So after I was working for AIDS-CAP here at the University of Washington, in 1997, I went to CDC as the director of international STDs, and really we had multiple different programs that we were working on. I think one of the most interesting programs we were working on was the Gore-Chernow-Mirden Commission, which was Vice President Gore and then the Prime Minister of Russia, Chernow-Mirden. And this was a project that was set up by President Clinton and Yeltsin's in 1993, but we started working in 1999. But it was to deal with a big syphilis outbreak in Russia. So it was quite interesting to work in Russia at that point in time. And that's not how I heard about PEPFAR, but just to say that it was a very interesting time to work in Russia, and also ended up with us working then with intravenous drug users and HIV in Russia during a time of transition after the fall of the Soviet Union. But then after that, being the branch chief for international STDs, I transferred over and became the branch chief for prevention for the Global AIDS Program at CDC. So I was the prevention branch chief, and we first heard about LIFE, so the LIFE initiative, and that was great because we had been working with a very meager budget and only in certain countries. But the LIFE initiative, you know, the prevention of mother-to-child transmission was a very important intervention. And then also it was the first opportunity to really work as a U.S. government interagency team. And then I remember hearing, you know, President Bush give the State of the Union address in 2003, and it was just amazing. We were so excited. Because, you know, when you're dealing with like, oh, I have $175,000 to do this project in this country, all of a sudden you had resources, and you knew what the resources could do because you were making progress, but it was limited by the resources. So it was so encouraging, and we were just so excited. And to be part of it too as CDC, that was really exciting.
Could you talk a little bit about your role as the prevention coordinator? Like, what was a typical day like? Like, what were you doing in that role?
Yeah, at CDC? Mm-hmm. Yeah, so in our branch, we had testing and counseling. We had behavior change communication. We had sexually transmitted diseases. We had intravenous drug users, programs for intravenous drug users. So we had multiple different programs in multiple different countries. So we were doing sort of, specific countries had a specific program. So my job was sort of to understand what each of these different groups in my branch were doing, and to sort of monitor those, and to to make sure that the right types of programs were being done. But they were being done at a lower scale in a country, in a CDC environment. It wasn't yet the interagency environment.
Okay. So let us now transition to the Office of the Global AIDS Coordinator, where you were Senior Technical Advisor, Deputy Director. You'll just help us align exactly.
Sure.
You know, we stalk professionally, so sometimes we're not so accurate.
Yeah.
So, like, how do you get to OGAC now from CDC?
Yeah,
just
so
explain the transition.
Yeah, so Ambassador Tobias had asked for a document to be written for ABC guidance, abstinence, be faithful, and condom guidance. And USAID had taken the lead on that document, but he wanted CDC to have input. So I was invited to go up. I actually went up for 2 weeks to help in the writing of that document. And then I went back to CDC as the prevention branch chief, but then they kept on asking me to come back. So eventually, for about a year, I would spend 2 days a week at OGAC and then 3 days a week at CDC trying to do the branch chief job. And finally, I think Mark Dybel said, just come, you know. So I transferred up. CDC then detailed me to the Office of the Global AIDS Coordinator, and I was working on technical. There were only about 12 of us there at that time. So as a CDC, I had the opportunity to engage a lot of technical people as sort of a resource. So that's how I became a technical advisor. But at that point in time, it was more in prevention than treatment. We hadn't really gotten into a lot of the treatment, but we we emerged into that, and then I took on a lot of that, more of that portfolio.
Gotcha. Okay, so you now come to this new established office at OGAG. So when you get there, what do you understand to be the mandate of that office, and how did you find the status of the office at in terms of like its early formation stages?
So at that point in time, there were two of us that were really sort of helping, at that point, Mark Dybel, get programs going. Michelle Maloney-Kitts, who was from USAID, and I was the CDC person. And then we were trying to figure out with Mark what were the best ways. You know, we had 15 countries that had resources that it was quite a lot of money that we weren't used to having that level of resource. Trying to figure out, okay, in each of these countries, what is the process for getting a plan and getting the right partners engaged? So some of the things, there were different groups that were helping in terms of the planning. There was a group called the Deputy Principals, and the Deputy Principals were the heads of, say, HIV activity at USAID, the head of the Global AIDS Program at CDC, from DOD, and then there was something called the Principals, and they were their bosses, so like the head of CDC, the head of USAID. And those were groups where we would present different, okay, we think we should have a COP, a country operational plan, and those groups would give their input and approve it. And then some of the things that we did for programmatic work, we looked to establish coordinators. Someone at the Office of the Global AIDS Coordinator who would be, so there were coordinators in country that would be State Department employees and directly report to the OGAC office. But at the OGAC office, there were also people who were their backstop. So they were, you know, if you were sitting at OGAC, you might have Kenya and Nigeria as your countries, and you would be in daily dialogue with them. Because there was a lot of, you know, understanding how to get the monies transferred, what agencies to transfer to, how to get plans written. And then one of the things that we started to try to fill that interagency space was technical working groups. So we established, I think initially, eventually there were like 16 technical working groups, but they would have members of people with those expertise from USAID, DOD, Peace Corps, and CDC headquarters, but also field personnel that would all say that they're all going to come together and talk about, say, OVC, you know, that, or, you know, prevention or something like that. So there was this opportunity for interagency dialogue at headquarters, but also engaging the field to get sort of a reality check onto what did that mean when you're trying to translate that. There was a lot of guidance documents to write as well. So, and we worked very closely with WHO because WHO and guidance really has, it's WHO guidance in country that has sort of the authority for countries to adopt that guidance. So we worked closely to make sure that our guidance documents were in line with, or we worked with WHO to develop new guidance documents and have those implemented in country. And also to make sure that we were working, it wasn't just an agency working with agencies, but we had to engage ministries of health and the non-government sectors early on because, you know, the agencies themselves couldn't be the implementers. They had to work through partners, whether it was governmental partners or non-governmental partners for the implementation of the program.
I see. So now I'd like us to talk more about your deputy director role because I'm more interested, you know, getting into like the treatment phase where art was now available and you're in this office, you know, at the headquarter level. So walk us through like a day, you know, in the life of a deputy director. What did you really have to do? What were your priorities in that role?
So I think, you know, before I was the deputy director, I was the director for technical activities and programmatic activities.
Let's take it from there then.
Yeah. So that was very interesting because we had the technical working groups to deal with, but I also dealt with all the people that were interfacing with the coordinators in country. So I think that was really helpful as a technical person because every morning I would meet with the people that were talking to the countries. You know, we would have morning meetings of all the, because things were happening, you know. Every day there was another crisis in another country. We were trying to put, you know, fires out. So you'd understand what was happening on the ground. And then you would understand what were the technical issues behind that. So it wasn't just dealing with the technicals, but it was framing those technical issues within the context of the issues for implementation at the country level. So a lot of the work that I did was really, you know, interfacing with the people at OGAC that were dealing with the countries, and then interfacing with the technical people at OGAC, because we then got a, you know, sort of a cadre of people that would be in charge of treatment. We had someone in charge of treatment. We had someone in charge of PMTCT at OGAC. We had someone in charge of OVCs. So those people were in my unit, and so interfacing with them, but also interfacing, we had regular calls with the technical working groups so that we would have the input a lot from the agencies. I also was a member, Monday mornings we used to have meetings with the deputy principals, and those were very important meetings. So we would raise, Michelle and I, and then Julia Martin and I, and others would, from OGAC, would raise issues with the sort of leadership from the agencies, and then as a group we would, you know, try to resolve those issues. They could be issues about, we're having a problem with, you know, access to supplies, or because we were working closely with a lot of other partners, such as the Global Fund and others. You know, we need to have someone talk to the Global Fund to get drug distribution, or we're having a problem with the Ministry of Health, or we're having an interagency issues in this country. So it was those kinds of issues that were raised every Monday, and our job was to raise those issues but not make those decisions necessarily, and to have the really high-level decisions about were we going to change policy. For example, we did a lot of work on initiating VMMC, voluntary medical male circumcision. So NIH was part of our technical working group, and we knew from the NIH studies, randomized controlled studies, that they were going to show up to a 60% reduction in people who were circumcised. So we said, okay, we need to adopt that as something we can put into a PEPFAR program, because that is a one-time intervention that's lifelong, very cost-effective for prevention. And we didn't have a lot of male-initiated prevention modalities, you know, behavior change communication in men and condom utilization in men. It wasn't 100%. It wasn't giving us 60% prevention, you know. So, you know, that kind of policy about adopting things such as voluntary medical male circumcision, we would discuss that. We would develop a policy document. We would discuss it at deputy principals, and then we would put it forth to the principals. So the head, it would be like Ambassador Diable, head of CDC, Tom Frieden, head of USAID, Raj Shah, and they would make the final policy decisions about adopting. Yes, CDC will adopt that, but only after WHO adopts it. So we were like then working with WHO, so that in 2007 they would say, yes, WHO is advocating for voluntary medical male circumcision. So there were a lot of moving parts, but it built on obtaining sort of the knowledge that you needed, and then getting buy-in from leadership to make the policy changes. But ultimately, it was the U.S. Global AIDS Coordinator, Ambassador Tobias or Ambassador Diable or Gooseby or Birx, that made the final decisions, you know, but they had input from all these different groups.
Oh, thank you. I'm a little bit interested in the ABC and voluntary male circumcision. Um, how hard or easy was it to get a buy-in from interagencies, civil society, and especially faith groups around those kinds of issues, ABC and circumcision?
So if she's asking a question, you keep looking at me
Okay.
so that it doesn't look odd on the camera. So
Sorry.
just keep your ear there, but then focus on me. Yeah, go
So
ahead.
the adoption of VMMC had a lot of very strong scientific data to support it. There were lots of different sort of epidemiologic studies that had shown in countries where there was widespread circumcision that would decrease HIV rates. But then these 3 randomized control trials, it was hard to debate the evidence. So I think it was very easy adoption on technical groups. The real challenge was adoption at the country level. So in countries where there had not been widespread adoption of circumcision, such as Eswatini, it was very difficult to implement. And we actually had a program that was not successful, SOPA and GABE in Eswatini, where a lot of effort was put into trying to scale up circumcision, but I think we did not have enough sort of formative research to say it was going to be difficult because it was not culturally acceptable to have circumcision. And there was a lot of false stories about what was happening to foreskins and why the US government was doing that. In places where there wasn't that, such as Kenya, there had been multiple tribes or multiple groups that had, some had adopted circumcision, some had not, but you know, it was much more acceptable to do circumcision in Kenya. And Kenya was a real success story where they were able to rapidly circumcise men. And so I think that it really was a function of what was the cultural experience and how did you deal with the cultural experience. And the implementing partners, you know, a lot of the implementing they were more clinical partners because it was a surgical procedure. But there were faith-based organizations such as Eswatini, the Luke Commission, that took on a lot of circumcision work. And it was one of those interesting things where you could set up tents and do circumcisions in a football field, you know, for a weekend and get a lot of circumcisions. And then in some countries, the military took up circumcision. So it really was understanding what was the situation at the country level, understanding the cultural, and also understanding what were the messages that had to be delivered to sort of, you know, help people understand what was going to happen. But eventually, like, even at Eswatini, I remember boys wanting to make sure they were in school the day they were going to have circumcision opportunities at school. So, you know, it did catch on, and I think it just was a matter of appropriate introduction.
Thank you. We're just going to move along now. So you come to the office and you understand your role as you have explained, but what were the priorities for the office? Because those were early formation years. I mean, like, what was the office aspiring to really achieve around those years? Because I know also PEPFAR being new, there was a lot of pressure about data accountability and all of that. What were like maybe the top 3 priorities for the office at that time?
Well, you know, I was there for 10 years at OGAC. So I think I worked with all of the from Ambassador Tobias, Ambassador Dybel, Ambassador Gooseby, and Ambassador Burks. So a lot of there was an evolution in terms of the resources and the number of countries and just also the science. So it was at that point in time where we saw really an introduction and acceleration of treatment. So, for example, you asked about in 2013 reauthorization, you know, there was 50% of the PEPFAR money had to be spent on treatment and care. And, you know, that wasn't necessarily the case in the beginning, but it was as we accelerated, and then we saw that actually treatment and getting viral load, lowered was actually also a prevention modality. So I think it really depended on the stage and also on the priorities of the ambassador. So I would say that, so in the beginning with Ambassador Tobias, it was setting the ground rules for what was PEPFAR. There was a lot of pressure in the beginning of PEPFAR for it to be everything for everybody. And everybody wanted a piece of the pie of these new resources. But Ambassador Tobias, coming from the private sector, really understood the need for focus and also to be able to do whatever, he used to say, whatever you measure, you do. So it was, we had to, and then also to understand the politics of, we had to be accountable for the resources that we were given in order to be able to justify additional resources. And I think that was something that also Ambassador Deibel was very successful at. Ambassador Deibel really was excellent at sort of engaging the Congress and a bipartisan support for PEPFAR so that the programs could expand and the resources increase. Ambassador Gooseby at that stage, I think he was very interested in making sure that governments were being heard, and that PEPFAR was really under the auspices of different governments, and it was part of their overall health program. And then Ambassador Birx, she was very engaged in data and real-time understanding of data for program planning and accountability. And I think that really helped direct the programs for the most impactful program and the most cost-effective program. Because you could say real-time, where were your incident rates not measuring up? What populations, what areas? So that the countries, and the data analysis was being shared by not only the US government teams, but they were engaging governments, they were engaging partners in this real-time data analysis.
Okay, I see. So during your tenure in the office, there were 3 different OGOG ambassadors, just like you said, actually more, because it's Tobias, yeah, from Tobias up until Birx, right? So we were talking about you working with the 4 different ambassadors, and how was your experience with that, and how would you characterize leadership for each? Like, what's the most important thing for each one of them? And then we can move to the next question.
Well, I don't know if I can speak for them or say what their most important thing was, but my experience was like, for Ambassador Tobias, I think his experience in the private sector was very helpful in the focus. And also, he had great experience in terms of managing different authorities, because he had to bring all these different agency leadership together and understand how do you make a team from very groups that weren't used to working together. And Ambassador Deibel, I have to tell you, he's like a mentor and a role model for me. He was someone who was technically superb, had amazing vision, and had compassion. And I think he was an inspiration for all of us, and he kept us focused on why we were there, the reason we were there, the people we needed to serve. And I think that was really important, but he also understood that there was a need beyond just the 15 countries, because we were doing a lot of good work, but there were lots of other needs. So he worked really hard to expand the number of countries and the support for other countries because of the overwhelming need that we were now in an opportunity to help. Ambassador Gooseby had a lot of experience domestically with Ryan White. So he understood just what was the long-term issues in terms of maintaining the treatment and care, that you had to have the infrastructure in country and the buy-in from country. So we had country partnerships. We had the MEPI and the EPI programs. But the MEPI and the NEPI programs were making sure that medical schools and other schools were able to do the appropriate medical training, so that there could be a future of people who were able to address and deal with the problems. And then Ambassador Birx, I mean, her emphasis on data was really important to make sure that the resources we had were having the impact. And I think the impact that we had, especially during her tenure, was due to her ability to give us that data so that we could focus and get really a lot of impact for the resources that were being invested.
Mm-hmm. So, I mean, let's also talk about not just their priorities, but then how did that, gel with the administration that was there? Because some of them would serve under different, president, and the president also has their own priorities and all of that. So can you also just talk about that? How was that? Did it change anything when a certain administration was coming on board, or you felt that they were not interfering with?
Yeah, I think the administrations, while I was at OGEC, were President Bush and then President Obama.
Yeah.
And I think, one of the things about, President Bush and his wife were very engaged, and they really were champions of PEPFAR. And they made the effort to go to the countries, to meet the people, to understand the program. And then under President Obama, Secretary Clinton was very engaged. And I think part of her engagement was that she knew Ambassador Gooseby very well. And so she was very up to date on what was happening, and very engaged. And she did a lot of, every country she went to for anything, whether it was for another issue, she always raised PEPFAR. So she was a great advocate for the PEPFAR program. And so was Secretary Kerry. He also was. So I think we always had great support from the administrations.
I see.
And we also had bipartisan support. And I think we shouldn't underestimate the fact that when you have bipartisan support for a program, that there's a lot of buy-in from administrations.
Mm-hmm. Okay, so Deborah, Ambassador Birx, as you have said, she really put the nail on the head about data, which was like a game changer. So could you just explain, how did where was that coming from? Is it because of her background? I know that we're still trying to get her to be part of the people we interview, but based on your understanding where she came from, where that passion that she was able to pass through into PEPFAR and how did she make sure there was this kind of buy-in about data and making data-informed decisions?
Yeah, so my experience with Ambassador Birx was really at the country level, because we overlapped in OGEC only for a short time before I went to Eswatini.
Okay.
But, she had been in PEPFAR from the beginning. She was part of Walter Reed. So her initial integration into PEPFAR was as part of the DoD. And then she went to be head of the Global AIDS Program or the Division of HIV and Tuberculosis in CDC. So, she was then my boss at CDC. So her experience was throughout PEPFAR. So I think what she brought was her experience, from the military all the way through CDC to her role as ambassador.
I see. So were there other critical actors, major actors in OGAC during your time? I know that we've spoken about the different levels and the structures and maybe talking about the multilateral connection with Global Fund, WHO, UNAIDS. How does the OGAC office work with those people, with those entities?
So my interactions were mostly with WHO, basically because it was more technical and guidance documentation. The people who dealt with the Global Fund were much more the ambassadors. And then Ambassador Deibel went to become executive director of the Global Fund. So it was at a much higher level than my level, that interaction.
Understood. So one of the key processes that made PEPFAR a success was the COP. And we know that before it was decentralized to the country offices, it started at OGAC. So since you were there in the formation years of OGAC, can you just explain to us, like, how was the COP process and what it looked like in DC?
Okay, I have to say that I've been trying to deny the fact that I was one of the instigators of the COP for a long time. 'Cause it's,
You are.
no, it was trying to have an integrated plan for a country for the expenditures, and understanding, also to get buy-in from partners, because you know, you have X amount of money in a country. You can't just give it to partners and not have it integrated into an overall program. And I think
Sorry, by partners, who do you mean?
so before the way people implemented USAID would go into a country, and the USAID office would give a grant to, say, PSI, and PSI would do a program, and it would be with USAID country, Mali, let's say.
Gotcha.
But what you needed now was one integrated plan. You couldn't just have, you know, individual agencies deciding what they were going to do. And I think the governments really appreciated that, because I remember the first time I went to Mali in 1991, meeting with the Ministry of Health, and they're like, "Who are you? Are you these people? No, didn't they just come before?" You know, it was all this confusion, like NIH was coming, DOD was coming, but the governments were confused as to how did that fit in with their programs, who were all these different people. Sometimes they were working at cross purposes or duplications. So I think this was an effort to have one U.S. government plan, and also to make sure that everybody understood, both at the PEPFAR level, but also at the government level, what was being done for the resources that were being given. And then that also helped in accountability too, because, you know, if you say, it's a very different thing between USAID. I think this is something that people don't understand, or I understood because I had worked as CDC, and also I had worked as CDC working for USAID, so I understood that. But CDC does cooperative agreements. So you give money to an organization like, say, Georgetown University, and you continue to have a relationship with them. So you might meet with them monthly, you might meet with them, and you can change the plan as you're going and work together. Whereas USAID's process was one of giving grants. So you had a deliverable at the end of the grant period, and the partner was expected to deliver on that. But you didn't necessarily have input to the process until, you know, for the deliverables at the end of the grant period. So those two mechanisms were very different. And so I think that was a little bit different on how people worked. So I'm sure if that answered the question.
It does, because I think for the first time I've been hearing about COP and all of that. I knew that there was that, it was a unifying factor, different stakeholders coming together, but I think also the issue of duplication, and like how you're just explaining it in Mali, where you'd come different times and overwhelming the government, you know, different times, different priorities and all of that. So the COP was like putting everything together and putting everybody in one roof so that they can be able to understand and make sure that, you know, there's no overlaps, and, you know, you just run on your lane and you focus on what you're an expert in. So.
Plus transparency, because these COPs were online. Anyone could look at them. There was this effort of being totally transparent. So you knew how much money was going to X, Y, and CDC. You knew what CDC was going to with that money. And you would see, did they deliver or not? You know, and a lot of what happened in PEPFAR was, you know, the better you performed, the more money you got initially, you know, eventually. So performance was really, especially when I went to the country level, we understood that we had to perform if we wanted to maintain or get more money. And it was very evident to everybody where our money was going and what it meant to perform.
Gotcha.
So overall, how would you say that enhanced PEPFAR work in general?
I think it gave us a comprehensive program so that we understood in each of the different domains we were working, was it regionally, who was doing what, in the technical groups, who was doing what, and we could say, do we have a comprehensive program? I think the second thing it did was the transparency made us accountable, which helped in terms of getting buy-in from the Congress to say this is a good investment because look at these people are saying what they're doing and they're delivering on what we're giving them money to do. And then thirdly, it made the governments understand what the different, it made the Ministry of Health and the government of the country you were in understanding what was a U.S. government investment and where was that money going. And often they wanted to know who are the partners because there was a lot of question about how much money is going into overhead, how much money is going to program, where is this money going? So we could tell them exactly where the monies were going and how much money was going where.
So now you have this process taking place at DC. So could you just understand what methods were being used to inform a change or focus from country to country, from the decisions that were taken from DC?
So the evolution in managing the countries was, I think, there was, PEPFAR developed, I think, stronger and stronger relations with the countries. And eventually under Ambassador Birx, there was a team at OGAC that was directly responsible for a certain country, and they went to country often, so there was much more interaction between the country teams and the OGAC teams. Whereas when we started off, you'd have one person at OGAC or two people at OGAC, and we would do COP reviews over the phone, but it could be a different team each year reviewing your COP. But there was continuity in the headquarter teams, understanding, and I think that led to a better understanding of the programs in country.
Okay. So did you experience any tiffs among the agencies when you were there?
Yeah, I mean, I didn't have a lot of tiffs with the agencies, basically because I had worked very closely with USAID and with CDC.
I see.
I didn't have that much interaction with DoD, but they weren't a major player. So I sort of understood the programs and how they worked. And I think also, I had developed, being in Washington, I had developed relationships that I think helped with trust. But at the country level, there were countries where there was friction. I won't say there wasn't. And a lot of times that is where the deputy principals would get engaged. So, you would meet on a Monday morning and say to CDC, USAID and USAID program directors, okay, your people in X country, you need to get them together and have them stop worrying about X, Y, and Z. So, we weren't necessarily the people who intervened in those TIFs as much as, say, understand what the TIFs were and got the right people to engage. Now, the ambassador, I think, sometimes was helpful. He had that authority. If there was ultimately a problem, the ambassador would get engaged. But I never had that. I mean, there may have been other issues that I wasn't aware of that had that kind of TIF. But on the technical and programmatic level, I think we were able to deal with that through the deputy principals. And I think that, they dealt much more with dealing with the TIFs than, say, OGAC, at least I did. And rarely, sometimes when there was when I was in country and there was a problem, say I was the CDC director and there was a USAID director and we didn't agree on something, we would ask the headquarter technical teams to come out. So let's say there was a problem with, I don't know, circumcision or something, and we'd say, okay, we don't necessarily agree with this. Let's get the technical team to come out. And the technical team would have a USAID, a CDC, and other people on it. And then we would sort of say, okay, let's see what their recommendations are. so that there was an arbitrator in the dialogue, and it wasn't necessary. Because in country, you don't want to have hard feelings. Because in Eswatini, my desk was next to we integrated desks, so it wasn't like a CDC office and a USAID office. It was one room, and we all had different desks, so it was PEPFAR. We weren't necessarily USAID. So, and you were friendly with everyone. You didn't want to have a bad relationship.
So you were at OGAG when the reauthorization in 2008 took place, right? So can you just walk us through, what was the preparation process like for that renewal?
So I think the important thing, and especially I learned this from Ambassador Dybel, was that, reauthorization is facilitated if the decision makers understand the program. So throughout his tenure, we always had staffers for the different, say, committee leads, their staffers come to PEPFAR meetings, and we would brief them regularly. So I would go to the Hill and say, okay, we're going to do circumcision. Let me explain circumcision to you. Or we're going to do X, Y, and Z. Or they would call us. I remember one senator, she used to call all the time to ask me to come and talk about OVCs, because that was her issue. They had certain issues. And then their staffer would say, Ambassador, Secretary, Senator so-and-so wants you to come and tell her what's happening with X country and OVCs. So a question was making sure people understood the program. And also we found stories. People's stories were very compelling. And to try to collect from the country level the appropriate stories, and then also to arrange site visits for important people. So I think that ongoing messaging about what the program was, the impact it was having, and making sure that people were fully informed helped the process. I think the controversial part about 2008 was that it was the Lantos Hyde legislation. In that, it said that 50% of prevention had to be spent on abstinence and be faithful. That was a directive. But one could write, if there was a reason you couldn't do that, countries were allowed to write an explanation as to why that was not possible. But that was a mandate at the time from that legislation.
And then also we know that PEPFAR was conceptualized out of conservative values, and the issues of abortions and key population and all of that.
Yeah.
Did that have
so
an
abortion,
issue in
the Mexico City,
Yeah.
the Mexico City legislation, we weren't allowed to support any partner that also supported abortion services. So there were some partners that did not get funded because of that. The key population didn't have the same, there was dialogue about that, but there wasn't the same kind of restrictions for key populations. But I think a lot of it was much more, the work in Uganda very much influenced the ABC dialogue. And I think that understanding how the epidemic was progressing from the time that was impactful in Uganda, and then the other resources that we had, for prevention, I think assisted us as we went further.
So, 2013, is there anything significant about the reauthorization?
Yeah, so the reauthorization in 2013, again, we had done a lot of work. I mean, you start working on reauthorization like a year ahead of reauthorization. It's not something, let's just write this document. No. It's something that's a process that goes on. And it's an important process because you've started all these programs and there are all these people dependent on you. You have to make sure that there's resources available to continue that work. So I think the thing about 2013 was that we really had tremendous data suggesting the impact for both treatment for both, treating infections, but also for prevention. And so there was legislation in that said 50% of the resources should go to treatment and care.
Okay, so we're going to move on to your position in Eswatini as CDC country director.
Yeah.
You get tired of the global, headquarter, proceedings, processes, and why the move to Eswatini? How did that come about?
So I always wanted to work in a country and be a country director.
Okay.
But my parents were both ill, and so I needed to be in the States. And then my mother passed away. My father had passed away, and then my mother passed away in October of 2014. So then I didn't have that same obligation. So I went to Eswatini. I took a job in Eswatini. It was a job that was available, and I also wanted to go there because I had been to the country. And one of the things that really impressed me about, two things impressed me about Eswatini. One was that it was a really important epidemic. It was the #1 health issue in the country. That wasn't necessarily true in other countries. There were other issues, but the focus was truly on HIV. And secondly, there was a very dynamic, committed Ministry of Health and people to work with. And I had met Dr. Okello, I had met Rejoice, and very impressed and wanted to work with them.
Mm. So you had met them whilst you were still at CDC prior and still
No,
at
when I
OGAG?
was at OGAG.
Okay.
Yeah.
I see. So you wanted to go where there was already rapport.
There
and
was a
commitment.
rapport, but there was really a good partner to work with,
Mm-hmm.
and a problem that needed to be addressed, and progress that was being made.
I see. So you get there physically now. You don't read about it in papers or hear from, the representative from the Ministry of Health. So how do you find everything when you get there in person?
I'm trying to figure out how I found it.
Like structures, infrastructure, funding, partnerships,
So when I got there, there was
Just
a
scoping.
change in the way the program was being implemented. So before, and I didn't develop that change. That change was just being implemented when I got there. So they had been doing programs where each of the different implementing partners had been in charge of a specific technical group. So let's say EGPATH was in charge of prevention of mother-to-child transmission, and ICAP was in charge of treatment. So, and they were going around to the different clinics, and the clinics had been complaining about, okay, 5 people are coming to my clinic. I've got EGPATH this day, I've got ICAP this day, I've got URC this day. And so what they had done in the NOFOs, which are the funding opportunities, they had written it so that instead of having technical groups, they would divide the country into the 4 regions. And so different partners would take on the entire comprehensive program at a regional level. And so when I came, that was just being implemented. So I think that was sort of the change, where instead of the entire country to be working at, I now was just really responsible for 2 regions. And our regions were Manzini and Lubombo.
Do you know how those decisions are made? What informed that change, like from countrywide, national into regionalization, for instance?
So that was before my time. You can ask Dr. Aaron Krantz that question. Okay. I think he's the one. But I think it was complaints.
I'll note it for him.
Yeah,
Okay.
so I think it was complaints from the clinics themselves that they were being overwhelmed with these different people coming in. And each, you have one nurse and, she's got 3 different people telling her what to do, and one person wants her to do nothing but PMTCT, the next person wants her to do everything for treatment. So I think it was trying to be realistic in what were the capacities, and also to make sure there was an integrated program.
I see. Are there any challenges that were unique to Eswatini despite having great leadership, partnership, and the program already underway? Like, what then were you able to see as unique challenges for Eswatini when you arrived or during your tenure there? If there's none,
No, I think I was very lucky because I went to a great program that had been well established, and wonderful partners, excellent partners, and an excellent Ministry of Health. I think for me, one of the challenges was just the impact the epidemic had on people. It had devastated everybody in the country. no one was left untouched. And so there still was a great sense of mourning and still fear to a certain level. But I think there was also hope, because I had seen, you know, treatment come out and have impact. I think the other thing I was engaged in was working with women dying of cervical cancer, because there were, given the number of women impacted and, you know, the propensity for cervical cancer and HIV positive women, I would go and work on the wards with women dying of cervical cancer, and that was a difficult disease. You know, there wasn't a lot of opportunity to treat cervical cancer, so we did work trying to get some oncology services into Eswatini, but it was very difficult to get.
Because it was already advanced, or there was
Yeah,
just
they were
no
dying.
infrastructure?
Yeah, you know, Mobani General Hospital, there was an entire ward of women dying of cervical cancer. It was quite sad.
And they were not responding to treatment?
There was no treatment. They didn't have chemotherapy, and it was too late, really.
Yeah. Okay.
So I think that, you know, it was seeing sort of the end stages of disease without the same kind of opportunities for treatment.
I see. So moving from OGAC to the country office, do you feel that you had like a unique advantage, you know, position over, you know, coordinating the response on the country level, because you had some know-how and experience from OGAC that made it very easy for you to work in the country office?
Well, I think it works both ways. You know, I also was at a deficit because all my colleagues had a lot more experience working in countries. So, and I had great colleagues that had a lot of in-country experience, having worked in several countries. So I would say the benefits were that I understood why some decisions were being made. So sometimes people say, like, why are we being asked to do this? And I would say, oh, because, you know, we need to show the Congress this, you know, or, you know, this is a bigger issue at a central level than just here in Southern Africa. You know, so I think that it gave me an insight to explain some of the requests that came from headquarters. And I understood also the need for headquarters to come out and see, so that there was a close interaction between OGAC and the headquarters team. Because sometimes people don't want people from headquarters to come, you know, like, oh, let us just do our work. But I knew it was
over our operations.
Yeah, I knew it was important for the headquarters to be engaged and to come frequently and to see our programs. And I also knew, like, we did films and videos when I was and we would send them to people, like, okay, we just made a video about X, Y, and Z. Do you want to see it? You know, and I think we understood the need to be promotional.
Okay, so you know, we've had to deal with the preconceptions about a lot of people not being really aware of what is in Africa, because, you know, also in the beginning of treatment, you know, we had concerns about, you know, people in Africa, they have no sense of time and we cannot take treatment there. It's some of the things. So here you are, you believe that, and especially during Ambassador Burke's time, you say it was important for country teams to go out there. So did you receive any of the people coming out of the States and who were not really clued up about Africa having to deal with stereotypes and explaining certain things, and coming to the country office really helped them to see things in a different dynamic?
No, because everybody who came from the country office was coming from PEPFAR. You know, it wasn't like, so it was just the visitors. But
no, I mean the ones coming out of DC to the country.
But from the OGAC office?
Yeah.
Oh, the OGAC office understood everything. We never had that problem.
Okay.
But I would say that, you know, there may be people, I mean, those questions about people can't tell time, I mean, that was ridiculous. But, you know, I think that was very short-lived. I think that got a lot of press, but it was just
prior to PEPFAR.
It was an individual,
okay.
You know, and I think the data showed that was truly not the case at all. Uptake of antiretrovirals, you know, adherence to antiretrovirals was very, very strong. I mean, the adherence in Eswatini was greater than the adherence I had had in Seattle. You know, it was just much better adherence, and it had nothing to do with some of the preconceptions. Now, when we had visiting congressional teams or other teams, we made a point of making sure that if they had any questions, we could, answer those questions. But even the people that came from, on congressional visits, were very, they had gotten good, I remember going on some of those visits when I was at OGAC, and there was lots of briefings before we went, so people were well informed.
They knew what to expect. Okay, so getting into the country office, I know at national level you have the rapport and the relationships. How did you broker relationships with implementing partners and, hospitals and all of that? What would you tell somebody who wants to be a CDC country director, how they can create, viable and healthy relationships and connecting with the role players at the country level? What was your experience with that?
So I think, first of all, it's important that you have a PEPFAR team and it's not an agency team. So
clarify that.
Okay, so like in Eswatini and even in Ethiopia, I never thought of myself as, I was the CDC director, and in Ethiopia it was a little different because I was in charge of many other things. But in Eswatini it was only HIV. So the CDC director in many countries such as Ethiopia, I was in charge of immunizations, emergency COVID, emergency response, all the TB, malaria, all the other things. Whereas in Eswatini, it was only HIV. And that was very helpful. But we were working as one team, as a PEPFAR team, under the auspices of the U.S. ambassador in Eswatini. So I think this concept of an embassy-based PEPFAR team is important. And then the implementing partners we had were excellent. I felt like, we were one team working together, ICAP, and we were very engaged with them, and URC. We met with them on a regular basis. We understood what was happening. We went to site visits. So I think that, I sort of felt like I was part of the ICAP team and part of the URC team, being fully engaged in the SHIMs, which were the FIAs, and understanding, I think the close communication was very important. And then I think also I was very fortunate to work with some amazingly talented people, especially country nationals, so I learned a lot from my colleagues, just who were, incredibly dedicated, lots of experience, fully committed, and they really helped me along. Like, I was a good listener.
I see. So let's talk about data and reporting. By the time you were there, data is very, very important. So what kind of structures were put in place in the country office to make sure that the data that's needed is collected and it's quality data? And I know that specifically for Eswatini, there was client information management system that was put in place to make sure that, data is collected and it's in one place. So how did that work?
Yeah, so I think in Eswatini, there were regular reporting by different partners. But I think one of the things that was different about PEPFAR reporting is before PEPFAR, different agencies had different variables they collected and different ways to collect it. Whereas under PEPFAR, there was one monitoring and evaluation framework, and the variables were the same, and everyone was collecting the same variables in the same way. I think, so that was very helpful. So regular reporting, regular analysis of the data with the partners and with the government, that was important too. In Eswatini, there was something very unique, and that was that they had done the first FIAs. And SHIMS 1 was done, I think it was 2011, but I was there for the subsequent two SHIMs. So it was the first time, the first FIA was done in Eswatini. And the data from that because we had a second one, when I first got there, we did the second FIA, and what we were able to show was a decrease in incidence. And that was very important because it was the first time that worldwide it had ever been shown that without a vaccine, and using programs, you could decrease incidence. You know, when people think about decreasing incidence, because we don't think about decreasing prevalence because people live with, you know, with antiretrovirals, but decreasing incidence, people thought, oh, you need a vaccine to decrease. But we had shown that comprehensive programs under PEPFAR had, well, you know, and Global Fund, because they were also there in Eswatini, there had been a decrease in incidence. And that was very groundbreaking. And in fact, Dr. Okello went to Paris to the conference, AIDS conference in Paris, and made that announcement. It was, you know, headlines
Phenomenal.
everywhere. And then we were able to show with subsequent FIAs that we could continue to decrease incidence. So programs were working, and that was important in maintaining resources for program implementation.
Who came up with the FIA's idea, if I may ask?
So the FIA, it's very interesting. You know, Soka and Kaba, for trying to get circumcision, didn't have the impact we wanted. But the evaluation of Soka and Kaba was really the first FIA, was trying to say, would there be a decrease in incidence if we actually had done the coverage of circumcision? So that really was the groundbreaking. It was really groundbreaking for an evaluation of the impact of circumcision. And ICAP had done that. But then that tool became valuable not only for looking at the decrease in incidence, but also for monitoring what was happening at the population level. So before, when we were doing work monitoring and evaluation at the country level, we were doing it by population and partner. We weren't looking at general population. So what these FIAs were doing was going out to the general population. We were looking at, you know, what were knowledge, attitudes, practices. We were looking at, for those that were HIV infected, were they taking their drugs? We were measuring drugs in blood to see if they truly were taking it. So we were looking at adherence. So it really was a comprehensive look at the population level.
Thank you. And that just brings me to think about prevention of prevention of HIV from mother to child. The PMTC. Did that play any part in this decrease in incidence?
Yes, so that's why Soka and Kaba was started in Eswatini, because one of the things that there was very good coverage of PMTCT. So, you know, it was initially like 1 in 5 women would transmit to their child. But then with the onset of PMTCT, that number was coming down, and eventually, I think in Eswatini now it's less than 2%. So it really is a success story. But we saw worldwide there was a success story from PMTCT, because there was good uptake of ANC clinics, and then there were good opportunities for treatment. Once we did, the treatment, comprehensive treatment of the women, they were adherent, they were taking their drugs, and then they were starting on antiretrovirals right away, So they were not only just taking it during the antenatal care period, they were also being initiated on treatment long term. So, and it was very good uptake, and it was I think throughout the world, PMTCT was a very successful program. I think less successful has been worldwide the number of children that are still not diagnosed and treated. So pediatric AIDS is still a problem, and you might say, why is that a problem? Mm-hmm. And that is a problem not because of PMTCT, but before PMTCT was really widespread. So initially in the epidemic, like when we were doing key populations and things like that, women who were positive could have had children. But then when you asked them, when you saw them and they were positive in their ANC clinic or another clinic, you would say, how many children would you have? But they might be afraid to tell you about their children because they were afraid the child might tell the community, or the father might find out that the child was positive and blame the mother, and then the father would leave the relationship. So there were early on there were a lot of reasons that women did not want to disclose who their children were and say they could be positive. So those children were never identified and tested.
That brings me to a follow-up question, because I'm just thinking about the coordination structure and how PEPFAR was making sure that there was support and having those technical working groups. So did prevention fall off the radar when treatment came in terms of like having a focus for that? Because I'm thinking from time to time I hear a lot of these cultural embedded type of issues that need attention, like, stigma, like fear and all these kind of things. How did PEPFAR, in their design, cater for dealing with these kind of cultural factors and issues? Also with the male circumcision, you said that because it was not part of the culture, it was difficult to. So was there any small group like structure or focus in terms of dissecting that and making sure that those are dealt with adequately?
Yeah, so there was a prevention working group. At the headquarter levels, there were prevention. But remember, each of these issues are somewhat unique to the country. Okay. So at the country level, there were prevention specialists. So I think it really was a function. It was a function of the country, and it was a function of the time and what were the available resources. So early on, these were issues. But as time went on and resources were greater and people's attitudes changed, because, stigma and discrimination and fear, stigma's always there, but it maybe have decreased depending on the country. Fear decreased when there was treatment. And over time, these issues changed. And now, a 15-year-old in Eswatini may want to get circumcised, whereas, a 35-year-old may not want to get circumcised. It really was a function of who was your target at what period of time and what were your resources.
So the prevention strategies never got that, the attention in terms of like doing a population level kind of impact as it did with, like, for instance, when you're doing the fears, it never culminated to that?
Well, it did early on. Remember, we had these KAPs surveys. Okay. So early on there were
prior
a lot
to
of
treatment.
Yeah, there were a lot of KAP studies.
But not after treatment was.
Well,
now
it depended on the group. So I wouldn't say they were as universal as they were initially.
Okay.
Just still a little bit more about the PMTCT. Were there any points in time that traditional birth attendants were part of that program in any way at all?
Yes, I think in many countries they were. Now, I think that's a country specific, because in some countries there's wide uptake of clinical PMTCT, whereas in other countries, like in Ethiopia, there's a lot of traditional birth attendants in some of the populations. So it really was a function of what was happening at the country level. But definitely they were included.
What was that like in Eswatini?
Eswatini did not have as many traditional birth attendants as other countries.
It was not mainstream in the health response.
No.
I suppose.
It was much more clinical ANC clinics. Some of the in addition to traditional birth attendants, some of the challenges for PMTCT was, and not so much in Eswatini, but in places like in Ethiopia, after your first or second child, you don't bother going to ANC clinics anymore. You're used to this, you don't bother to go. So getting women to go, and then in some places getting them to go to more than one visit was also a challenge. So there were different issues in different countries.
So talking about cultural issues that might impede health services that are available, would you say gender disparity and access to HIV treatment was a problem that you observed in Eswatini, or what would you say about gender perspective and access to care?
I think the issue of gender in Eswatini was really, how do you deal with adolescent girls? And because there were a lot of men that had relationships with multiple partners, especially with adolescent girls as partners. And then we had a DREAM program. So that was one of the issues in trying to have a DREAM program, in Eswatini is to try to get, because people, there's a denial about all kinds of issues when you're an adolescent, and also a desire to have resources, like whether you want a cell phone or new shoes or something like that,
Mm-hmm.
So it really was, those were more of the issues, the multiple partnerships and the young partnerships. And I think maybe also in Eswatini, and this was my impression, was that it may have been harder for women to have negotiated safe sex and to question their husband about multiple partnerships. So they were vulnerable because of that multiple partnership issue. So there was an increased level of vulnerability for women.
You said you were in Eswatini for 10 years, so dreams
No,
did
I was in
come
Eswatini for 6 years.
Oh, for 6.
I was in OGAC for 10 years.
Oh, gotcha. Okay, so like dreams, at what point did you find dreams already being implemented when you came?
No,
or
so
it came
dreams
after?
got implemented, I think, around year 4. So only
Close
for
to
like
your
the last
exit.
2 years of my work.
So it was still at
But
infancy.
the other thing that we did in Eswatini was we did VAC surveys, violence against children surveys. So we had done one earlier. The first VAC survey was actually done in Eswatini, the very first one, while I was at OGAC. And it showed very high levels of violence against children. But there were some questions in its implementation. And then, it was understanding what were the issues around violence against children and the vulnerabilities of children, and especially young girls.
I see. What kind of violence was that, if I may ask?
Oh, it's multiple different types of violence.
Okay.
Yeah.
All right, I can follow that one
Yeah.
up later. So part of PEPFAR's making, and we know that accountability for resources and productivity was important, but also there was the issue of partnership framework for the local government to own programs and to lead. So, can you talk about, as a country director for CDC, how did you make sure that the government was owning and leading the interventions in terms of like priorities? Like, for instance, you said there was the regionalization approach. Okay, that happened prior to you. But in general, your experience.
Well, no, I implemented that regional approach.
you
It was
implemented
just
that?
starting when I came.
Okay, so I really want to know, like, how does the government become like the leader and they own this? Because you can come with a concept, but how does it get accepted and adapted and implemented? Can you just explain
Sure.
how that
So
happened?
in Eswatini, we met with the directorate of the Ministry of Health, Dr. Akello, Rejoice, Simon. We met with them monthly. So we would debrief them what was happening in the program monthly. Our implementing partners also had close relationships. Like ICAP, I think, also debriefed the ministry and had close relationships with the ministry. I'm not so sure about URC. And I don't know what EGPATH was doing because those weren't my regions or partners. But I know we, as a PEPFAR team, met on a regular basis. And I think one of the things about Eswatini was the government was very involved even in procurement of drugs early on. So they had made a commitment to invest. And there was a lot of, the king, His Royal Highness had declared HIV a national emergency, which had really given a mandate at a multi-sectoral level to HIV as a problem. And he was very engaged. I remember having to help prepare his speech for when he gave a talk at the UN about, he was giving a speech after the FIA data that showed an impact because he had given a speech prior to that. So I think the level of engagement at multiple levels, from His Highness all the way down to the multi-sectoral response to a very engaged Ministry of Health, really helped a partnership framework. We weren't trying to forge any new relationships. Those relationships existed. And there was a level of commitment from the government to invest in an HIV response. And we had a very strong relationship with the Global Fund too. The Global Fund would come out quarterly and meet with us, and they weren't in country, the people from Geneva. So, I had regular calls with the folks in Geneva, because they would call us up with questions, because we were on the ground and we could help inform them. So I think it was at, WHO, UNICEF, and others were in country, and we worked with them. But I think also there was a coordinated Global Fund response and PEPFAR response as well. And that was both overseen by the government. I mean, the government was sort of in charge of that integration as well.
Let me just ask a follow-up question. This integration and coordination, because like when we spoke about COP, it was the implementing partners, the government and all of that, like aligning activities, resources coming together, one monitoring and evaluation framework. But how did that work in terms of, because you have other donors like the UN, would the resources come into one pot? Would they also report? How would you make sure that resources that are coming from the UN and the USG, does not fund the same things, that kind of thing?
Well, there weren't that many resources coming in from the UN or the WHO.
Okay.
Much of their resources were invested in personnel at the country level.
I see.
It wasn't really programmatic response. And so it really was, if you looked at who was investing in programs, it really was Global Fund and PEPFAR. And there was a close relationship there.
So how did you delineate between what then PEPFAR was funding and Global Fund? Because
so
those
we
were the
knew,
two purses.
Yeah, so we sort of divided and conquered. So if we needed reagents, or if we needed, so the different things were either reagents, drugs, or human resources.
Okay.
And those were sort of the way you divided it up. So PEPFAR would take on the human resources, and Global Fund might take on some of the drug. We might take on the pediatric drugs because we could do a comprehensive Southern Africa contract, because it was very hard to get pediatrics for the low numbers of drugs at economic prices for the volume. So it really was a question of, and it changed over time. Global Fund might decide we don't want to do human resources anymore. So then PEPFAR would take it on.
I see.
Or PEPFAR might say, with the WAMBO Global Fund procurement methods, you guys can get reagents cheaper than we can. So it really was a question of what were the opportunities of the different
and who was at
groups.
advantage position to do whatever.
And it changed over time.
And I see that there was really a lot of talking together, discussion, and reviewing the program and what challenges were there, and then taking a decision together.
Yeah.
You did mention that Eswatini was, I don't know if you said unique or was different, the fact that the government wanted to procure the drugs. Was that specific to Eswatini? How did the other
not all
countries deal with
countries, many countries relied on either PEPFAR or Global Fund. So in Ethiopia, Global Fund buys all the drugs.
Do you know why in Eswatini they were adamant to
Well, they
procure?
didn't buy all of them. They started off, but I think, looking forward, they realized these are necessary commodities. We don't want to be dependent if something happens, You can trust donors for so long, but you might have been burnt in the past, So you try to, if it's a necessity, you realize you need to make a level of commitment. And I think that's helped in terms of what's happening now. I wasn't in Eswatini for these new documents for the transition to government ownership that's happening now, but I'm sure it was easier in Eswatini than it was in other places.
Because the government was already in charge of they already had a budget for the drugs.
Yeah.
Oh my God, I had another follow-up question about that. Oh yeah. So because you are doing procurement and all of that, so I want to ask about system strengthening. For instance, because I know PEPFAR they beefed up the labs in the country, building capacity and all of that, and supply chain management being an issue and all of that. So how did PEPFAR make sure that those systems are supported, are sustainable, are stronger, so that, because supply chain is very important. If they're doing drugs, there could be issue of spoilage and loss, because that was not necessary. Was PEPFAR doing anything to strengthen the management of the pipeline, and also just fiscal discipline within the government? Because I know that there's also somebody from PEPFAR what is it called? The like the person that is within the government that manages the agreement.
Right. So yes. So CDC had two
it's CDC.
two programs.
Okay.
So one program was with the Ministry of Health, which was Ganile, you probably know Ganile. Yeah. So she was the director of the cooperative agreement with the government. And so that was an agreement in which it was sort of understanding that eventually we would need to transition to the government. And so, and then there was another agreement with ICAP to strengthen the laboratory. And within that agreement were the reagents and the procurements mechanisms for the laboratory. And at one time, URC was also in charge of laboratory procurement, but then it went to ICAP. So those partners worked closely. And, for the laboratory, that was a question of, facility improvement with equipment and things. PEPFAR built the blood center, the transfusion center, because there was no transfusion center. But it was also making sure there were resources available to do the types of testing that needed to be done in country, and also to make sure that there was training. So it's a question of personnel, equipment, and reagents. So those were the issues for the laboratory. And the technical partner was ICAP, and they worked closely. There was someone at ICAP that's their only job, there were two of them, only job was to work with the laboratory. And it was not just a question of the laboratory in Babani, it was a question of making sure, initially there were a lot of PEMA machines throughout Eswatini, but as you didn't need PEMAs anymore, had to transition out of PEMAs and get to transport and things like that.
Transportation.
Yeah. And so then the other question with Ganile was to have an agreement in which you were working with the government, but it was like a parastatal so that the money could go into a cooperative agreement. And eventually what happened was all the human resources that were being funded by PEPFAR were taken on by that agreement, so that the government was now, the money was going to that cooperative agreement, but it was the government under the government, procurement, personnel procurement regulations, because there were a lot of regulations around manpower issues. But so those mechanisms were being used, and so it wouldn't be a big, because that was a problem in a lot of PEPFAR countries. You come in and you pay people in this partnership, this program is getting X amount of salary to be a nurse or a doctor, and then the other nurses and doctors paid by the government are not getting the same salary. So it was a question of making sure there was equitable, so you weren't seeing that disparity, because then, people don't want to work for the government, they want to work for the partner.
Okay, another highlight in Eswatini when you were there was the 95-95. So tell me, how was it like to be there and be part of the major, role players for the achievement of 95-95? How was the vibe like?
Well, that was really what was happening, also with the FIA data. So we had a lot of very successful programs. So it was really inspirational and encouraging and amazing, and to be part of that was humbling. We just couldn't believe it was happening, and it was happening in a place that had such desperate, initial history.
And being the first to achieve it, right?
And the first to achieve it, so, and we got a lot. I remember being at the meetings with Ambassador Birx, and we got a lot of praise for that. And it helped us, when I first went to Eswatini, our budget was about $34 million. By the time I left, it was $72 million. So I think that helped us. We were a program that could perform, and so people were willing to invest in a performing program.
I see. Okay. So there is a comlink that also
Yeah.
was implemented in Eswatini. Can you just tell us
Sure.
at what point you were involved and what was that really about and why was it important?
It was really important because what happened, there was
Maybe
really...
explain first what
Yeah,
that
so,
was.
so what happened in Eswatini, and it happens all along throughout Africa, you know, you have counseling and testing. Someone gets tested and they're positive, but they never get to the clinic. It's very true for men. It was that linkage from knowing you're positive to getting linked to care. Because that's, you can test all the people you want, but if you don't get them on care and you don't get them virally suppressed, you're not having the impact. So that was the missing part, was how do you get the person linked to care? And many people had tried many things, and we were working with PSI, and we were doing mobile clinics, and we would go to construction sites, and we'd go out, and we would test men, and they'd be positive. So what we found was that it was really, people were afraid to go to the clinics by themselves. You know, there was a fear of going, there was a fear. So what would happen is you would test, you'd go, it would be a mobile outreach van, and there would be there would be someone there, an expert client, sometimes called, and that person would have done that, you know. So they had to go with the person to the clinic. So you're positive, and this person would go with you. They had to have for 90 days they would be your buddy. They would go to the clinic with you for your first visit. They would go sometimes for the first 3 visits, and they would also call you, and they would also do, if you had to disclose and you were afraid to disclose, they would help you with disclosure to families. So it was really to have a buddy to get you through this part. The other thing that they did there was, okay, let's get a CD4 count on this person so they know their CD4 count. Now, it was test and treat, but people, you could really impact people going for treatment if they knew their CD4 count. It was sort of interesting. It was like a tool to motivate. And then the other thing was people were clinically evaluated for tuberculosis and started on tuberculosis drugs if they needed it. And also we had a WHO clinical assessment to say what stage you were at. So right away they were sort of hooked into understanding their disease, and they had a partner. So we had so all of a sudden we went from less than 50% of people linking to care to over 86% of people linking to care with us. And we were getting men, especially men, and that was one of our weakest groups. So that was and it wasn't that expensive. You know, we were paying these expert clients, and we had the mobile sites, and we had a nurse, and we had a Pima machine. But, you know, it was really, for the amount of money we were spending doing multiple testing and then treating someone when they were very far advanced, it was cost effective to do the investment up front to get people linked to care and started on treatment.
Was that modeled or started in Eswatini? Or
So there were many, it was actually started in, I think, Tanzania. The difference in Tanzania was they did it at a clinical site, whereas we did it with a mobile site. But the first sort of linkage with those kind of people, so then that was funded, and we did it throughout Eswatini, but especially for men at the mobile male sites.
It was effective. Okay, so let's move to Ethiopia. You feel you're done in Eswatini and you moved to
No, I'll tell you
Ethiopia?
what, I could have stayed in Eswatini forever, but you're only allowed to stay for 6 years in a country as the CDC director.
I see.
That's the maximum.
Okay, that's why. So why Ethiopia? Was it just where there was a position or there's a reason why you wanted to go to Ethiopia?
Well, so I had a choice of countries. One country was in Asia and one country was in Africa. And I felt like my experience was stronger in Africa. And also, the CDC director in many countries is not just HIV. You do immunizations, you do, you do all the epidemic emergency epidemics, you do malaria, you do TB, you do all the other diseases. And so as an infectious disease doctor, I was sort of interested in seeing what else was going on. And I had a team of about 11 in Eswatini, and in Ethiopia it was about over 130 people. So for me, it was to sort of challenge myself to have a more comprehensive program in a larger program. And the program was very famous. It had done a lot of excellent work. The head of WHO, Dr. Tedros, had been the Minister of Health at the start of the PEPFAR program and very influential in the early days of PEPFAR. So I was I wanted to challenge myself.
I see. But your transition is happening right in the midst of COVID. Living in Eswatini to Ethiopia. I mean, I don't know whether you make reference to in Eswatini when it started or transitioning to Ethiopia, but how was it like and how did that affect how programs were being done?
Yeah. So in Eswatini, I was the only infectious disease doctor in Eswatini. So, I had a responsibility for COVID as well there. And Dr. Okello and Rejoice actually headed the Ministry of Health's
the committee
response to COVID, and I was very engaged in that program. I think the other thing that was hard for Eswatini was that we didn't have the clinical resources. So we had the labs and we could do the testing, but we didn't have ICUs. And then when the borders with South Africa were closed, all the oxygen came from South Africa. So now we didn't have oxygen in country. Eventually we all got evacuated. The US government got evacuated just because there were no clinical, but it was the only hospital that was really looking after seriously infected patients was in Lubombo. And so it was really a question of how do you mount a clinical response when you don't have the clinical resources. I think the Luke Commission also did a lot of the work.
Yeah, they established a center where they were producing.
PEPFAR paid for that. The oxygen.
The oxygen plant.
Yeah.
So did you also get evacuated in that process?
We got evacuated.
And when did you get back at that point, or that's when you transitioned to Ethiopia?
No. I think we were out for about 6 months.
I see.
4 to 6 months. I can't remember exactly.
The risk was still there. Why did you go back? Or how was that being managed?
I think what happened was maybe the borders with South Africa opened. It was a lot to do with the borders to South Africa.
I see.
Because before, if you got sick, you could go to Nelspruit, You could go...
Better care.
Yeah. And also because there was no oxygen. But I think the oxygen had come, and also I think there was more opportunities to get evacuated. Okay,
so now we are coming to Ethiopia in the middle of COVID, and there's also HIV.
Yeah, so there's HIV and COVID, but COVID was a much bigger issue. I mean, it's a very large, over 100 million people in Ethiopia.
Yeah.
So it was a larger issue. And I was also involved in vaccines and vaccine distribution for the COVID vaccine. So I think my first day, I actually was at the airport accepting COVID vaccine. So we were working closely with the Ministry of Health to figure out how do you do vaccine distribution, because it was a large population, and initially they had sent us the Medora vaccine, but you need -70 freezers. So we were trying to get the Johnson & Johnson so we could get it to rural areas, because initially we could only go to urban areas. So there was good clinical resources in Ethiopia. You didn't have the same problem as in Eswatini, but you had a lot larger population, and you had a lot more different types of populations you had to reach with different types of vaccines.
I see. So,
and there was also a war happening. So it was the Tigrayan War.
Threats at once.
No, it was a war. I mean, the TPLF, and we got evacuated because...
Again?
Yes, we got evacuated from Ethiopia In fact, I think everywhere I went, I got evacuated. It's probably not a good sign if I arrive in your country. So there was a TPLF. There was a war with Tigray and the government. And so, you know, what was happening was there were millions of people coming down from Tigray that, you know, trying to come down. They were coming to Addis. So we had like people on the streets, tons of people. They just didn't have a place to go, so they were like sleeping on the streets. So it was very confusing as to how you deal with all these people in a very, resource limited area. If they're all in downtown Addis with, you know, there weren't tents or anything like that. People were just living on the streets. And then the army, the TPLF, came down, and they were about 100 miles outside of the Addis Ababa. And they had also blocked the only food route to Addis, so there was only 4 days worth of food. And the army was about to invade, so that's why they got us out, you know, because they figured the army's only 100 miles. But eventually what happened is the government forces pushed back the TPLF, and then the TPLF went through Amhara, the region of Amhara. And as they went through, they destroyed all the health clinics. I mean, you should see the slides. It's just destroyed, destroyed, destroyed. You know, papers all over the place, equipment destroyed, buildings burnt down. So all of a sudden, you know, we were in Amhara, and we were in the whole country. But that region of Amhara, suddenly we had 65,000 people on antiretrovirals that had no access to antiretrovirals because their clinics had been destroyed. So we had all these different situations set up by the war that were really challenging.
How did you deal with that?
So it was, you know, and these people are moving around because they are trying to escape, you know. So we worked very closely with the Orthodox Church. And we had some great people. There was this one sort of bishop from the Orthodox Church, and he got all his parishioners that were on antiretrovirals to share their medications with their friends who they knew might be positive. And one of the things about Ethiopia was that CDC not only worked with the government, but they gave cooperative agreements to the regional health bureaus. So our money didn't go to, say,
Central.
URC. It went to the Amhara Regional Health Department, the Oromia Regional Health Department.
Independently so.
Yeah, completely different. They were directly funded through CDC to do the work, the HIV work. So the Amhara Regional Health Bureau, they were an amazing group of people. Set up tents, set up sites where they, like churches, anywhere they knew, and they got information out to the people, you know, that were fleeing, saying, if you need antiretrovirals, go to this tent on this day, go to this church on this day. And we reoriented where the distribution of drugs were. And within 12 months, we had over 90% of those people back on antiretrovirals. It's a real success story.
Yeah.
But it's really due to this amazing group of people at the regional
The
health
leadership.
bureaus.
Yeah.
They really worked hard. But it was under great duress and you know, risk to their own lives that they were doing all this work. But I think the church also was very helpful. I mean, the fact that people shared their drugs, I mean, that's really amazing, that kind of, you know, if you think I've only got this one bottle, am I going to give it out to my friends, or am I going to keep
How
it
do
for
I know
myself?
if I'll run
Right.
out or not? Right.
Yeah, so people
Yeah.
were very willing to help.
But that also talks about people being aware of the treatment that they are taking, enough to know that I'm on the same regimen as you, therefore I can share. Because I mean, I'm thinking from the top of my
Well,
head.
people were on a pretty stable, you know, pediatrics was different from adult, but if you were an adult regimen, you were on a sort of set regimen.
Unless you're on second line or something
Yeah.
like that.
Right, yeah. But there weren't that many people on second line.
Yeah.
Yeah.
Okay. So, I mean, it's a whole different set of experience in Ethiopia from Eswatini. But can you point out something that was unique about
Yeah, so one of the things
Ethiopia?
that was unique about Ethiopia was because it had started as one of the first in 2001,
15.
2003, It was one of the first 15. And it had, because of Dr. Tedros, it had a very, strategic, close relationship with PEPFAR and had done a lot of very good work, with the government. That's why, the monies were going to the government and the regional health bureaus. They also set up something that CDC developed, which was the National Institute of Public Health. The National Ethiopian... No, it was called the National Ethiopian Public Health Institute.
Okay.
EPHI is what we called it, Ethiopian Public Health Institute. And it had sort of started from this program that CDC had domestically called the FETP program, Field Epidemiology Training Program, that then went international. It was preceded PEPFAR by many years. And it had been an early FETP program. So they had started with a whole group of people that were trained in epidemiology. And so then the national laboratories were also established there. So they were not only they were sort of like the Center for Disease Control with the epidemiology and doing outbreak investigations and all that. But the national laboratories were there as well. So you had a Center for Epidemiology and Laboratory Work. It was sort of based on the CDC in a way, epi and laboratory. And that was well established, and CDC really invested a lot of money in that. So then when there was like COVID, or then with the war we had cholera outbreaks, and then we were worried about Marburg, and then Ebola in the refugee camps with Sudan. There was a site that had the expertise in epidemiology, that had the contacts at the regional level, and they had the laboratory expertise to do that work. So I think that was unique. Now, the people in Eswatini met when I was in Joburg. I also arranged for a meeting with the EPHI and the Eswatini, and I know that they are trying to set up something like that as well in Eswatini.
I see. So, talking about art expansion in Ethiopia, I mean, when you came there, how was the HIV program doing and the expansion of the treatment?
So Ethiopia, I went from a place where the prevalence rate was very high, 23%, 27%, to a place where that's general population. To the general population group in Ethiopia was 0.7%. Okay, so.
Why was it part of the 15?
No, because it's different populations. It's like, it's a large country, so it's a lot of people. But there were different populations, different areas, different cities that had much higher rates. So it was
not generalized, it was...
It was like focused either in a regional, mostly urban areas in different provinces, or among different populations.
I see.
So it was a much more targeted, sort of like the early epidemic under ACAPS. We were trying to do that kind of work to focus on that. But there still were hundreds of thousands of people just based on the population. 0.7% of 114 million people is a lot of people. So there still was a need, but it had to be a much more focused program than Eswatini. And the different types of programs you had based on the different populations you had were different. And also you were dealing with a war. So what happens in a war, there was a lot of sexual-based violence. And also there were a lot of, economic deprivation, and that leads to people having to go into things like sex work or things like that. So you had to think sort of, where is the emerging vulnerabilities, and how do we deal with emerging vulnerabilities before, they get really saturated with HIV.
So what was the prevention strategy like, especially during war, and then we had to work with Orthodox Church? Yeah. Were you able to do the ABC? Were you able to distribute condom? Yeah. Just tell us more about the prevention strategy.
Right. So, it depended on the population, and it depended on where you were and at what point in time. So, like Amhara had a very strong program until the TPLF decided to retreat back to Tigray and destroyed all the all
along
the
the
clinics. So what was happening in Amhara may be very different than what's happening in Oromia based on who their populations were. But all those modalities were being used, as well as trying to do testing and counseling, get people in treatment. Circumcision wasn't as big of an issue there. But the partnerships, our partnerships were mostly with the government. But the government and the regional health bureaus, they also had partnerships like the faith-based organizations. So it was more that we funded the government, who then made their own partnerships and funded those partnerships. And USAID did a lot of work with urban sex workers. That was one of the areas that USAID focused on.
Mm-hmm. So did you find Ethiopia to have indigenous knowledge systems at all? I don't know if you mentioned earlier that yes, yeah. So how strong were the indigenous knowledge systems in Ethiopia? Also including gender issues. Did you see they played a role in treatment? The HIV response or generally?
So the variability. There are different cultures in Ethiopia, multiple different cultures. Mm-hmm. And urban versus rural, and the south versus the north versus, it really depended. And there's very high level of education in some areas, and so there was no, and women were as educated as men, but there may be other populations where it was very, misogynistic, and the women were really not being given the same opportunities. But I think the war and the sexual violence, the number of cases of rape and sexual violence due to the war and these different factions, I think that was a new element to the epidemic that I hadn't experienced before in Eswatini. So I think that trying to understand, and also getting access. We had programs in Tigray, but we couldn't get up to Tigray because there was a war. So for a whole year, we had no idea what was happening. We couldn't even get antiretroviral drugs into the whole region. So, there are 40,000 people, and we have no idea what are they doing. There's no antiretrovirals. We don't know where they are. Did they escape and go to Addis? Did they go to Amhara? We just don't know. So it was really a hard thing to try to track people. Normally you know who's on treatment and you can track them and you can say how adherent they are. But if you have a war and whole systems are being disrupted, you have tens of thousands of people and you just don't know, where they are they getting drugs, what are they doing in terms of, what kind of safe sex are they having or not having sex? Condoms, who knew if there were condoms up there or not? It was very hard, and we weren't working with the military. It was hard to work with the military during war. So that was something that was, not really open to other partners.
So would you say the Ethiopian response was mostly embedded in working with the regional health structures than it was with, instead of implementing partners?
Yeah, so CDC, we had maybe over 10 cooperative agreements. They were all with the government, either the federal government or with the regional health bureaus, except for one, which went to ICAP.
Okay.
And that ICAP was doing more sort of a mentorship and training.
Clinical mentorship.
And training, yeah. And so ICAP was our only non-government organization. USAID did a lot more in the, community-based organizations, but their CDC did all treatment. So our budget was twice as much as USAID's, just because we did the whole country, as opposed to Eswatini where we divided it up.
Regions.
We did all treatment and care. And all laboratory and information systems as well.
I see. So how is the process of picking and implementing partner? Why ICAP? How did you
so what
come
happens
to make that
for
decision?
CDC, I'm not so sure about how USAID works, but for CDC, every 5 years you write what are called NOFOs, Notice of Funding Opportunities. And so you write what you want your partner to do. You can say, I want 3 grants, I want 5 grants, I want 10 grants. And then they have to write an application. So they write an application, but I never see it. It goes to Atlanta. And there is a group of people at Atlanta, plus they get people from the different countries. So when I was in Eswatini, I may have been reviewing applications for Kenya, you know. So they have people, but I would never see my own application. So they let the country people not be engaged in the selection of the partners for the new funding opportunities. So then, you know, like for the most recent, the funding opportunities would happen. You know, I did not know that Georgetown was going to win. I was just told Georgetown has now won your funding opportunity. Talk to Georgetown. You know, they're going to be your new partner. So that's sort of how it works. It's a competitive process reviewed by headquarters in other countries, but not the in-country where the award is being made.
I see. I think I have one last question here. So, anything that you're proud of that you accomplished in Ethiopia? I know that in Eswatini 95 and this and that, there must be something, and also like challenges that a balance of both in Ethiopia.
Yeah, so in Ethiopia, I think I'm very proud that we got those 65,000 people on antiretrovirals back on treatment within a year.
Yeah.
And I think I'm proud that despite what was happening because of war, we were able to maintain regional health programs for HIV. So I think that, and I'm also proud that we got vaccine delivered throughout the country, COVID vaccine, despite all the challenges. So I think that.
How did you make that work? I mean, if there was war going on and still be able to distribute COVID?
You couldn't get into some sites.
Yeah,
so wherever you could go, but you couldn't maybe get vaccines into Tigray. I think you could now.
Did you enlist the army in doing this, or it was still like the normal system that was working?
Government was the regional health bureaus were our
still
implementers.
Still the same structure.
Yeah, and Federal Ministry of Health. So I think I'm proud of that.
Any peculiar challenges?
In Ethiopia, or in Eswatini, I'm just proud to have been a member of that phenomenal team and to have been there. You know, I don't deserve any of the credit for it, but you know, there were a lot of very talented people, and I'm just thankful that I was there to witness that.
Challenges? What could be done better, either countries?
Gosh.
Well, actually,
I think the challenges are, you know, the challenge of continued communication to maintain funding. So I think that, you know, now is a tenuous time for PEPFAR. So I hope people understand the need to maintain funding for the program and the impact it's had, and the pride the U.S. government and the U.S. people should have in that they funded such a program. Because I think, you know, it's soft diplomatic power, and I think sometimes people don't realize how important that was in both places, especially in Ethiopia. Like, there are many people and donors in Ethiopia as opposed to Eswatini, and there were a lot of Chinese donors. But people used to always say to me, "Oh, we're so glad the Americans here. The Chinese don't help us as much as you do." You know, so I shouldn't probably say that. But anyway, you know, so I think that people, I think people, maybe we didn't do a good enough job telling people the benefits of the program. So maybe the storytelling.
Who are you supposed to tell? Like if you say you're
Well,
not
I
telling-
think the American people who are the funders, you know, the taxpayers of the government.
How do you think that could be done? Because I was going to get to that as we do reflections, but I mean, since you're talking about it, we might as well.
Yeah, I think, you know, Ambassador Dybel was really successful at that. I remember early on in PEPFAR, I actually went on a tour of U.S. cities to talk to like Rotary clubs and different groups to tell them about PEPFAR when we were just starting. You know, so it was to have contact with domestic organizations. And I don't think we did that as we went on. And I think maybe there were a lot of good news stories with President Bush. You know, he and Mrs. Bush went to a lot of sites, and there was always, I remember Ann Curry was with her in Ghana, and there was news, interviews and things like that. So I think maybe more of the sort of news stories, and then also the on-the-ground domestic dialogues.
You mean locally?
Yeah.
What shape and form would this take? I mean, like, who would lead them, and who would be like the
Well, you know,
the
it's really
audience?
interesting because when I was at OGAC, there were two people that always came to talk to the Congress. One was Dr. Tedros from Ethiopia, and the other was Dr. I forget her name, the Minister of Health from Rwanda. And whenever they were trying to decide on a bill, these two people would come and tell them what kind of progress was being made due to PEPFAR
So they were
funding.
invited by Congress.
They were invited by PEPFAR, by Ambassador Dybel,
I
to
see.
come, and we would take them around to talk to the different senators and Congress people, and then they would make a speech on the floor of the Congress, and so that people were hearing about what the impact was. And I don't think that's happening at the same frequency. But I think
So
it was
the
effective.
ambassadors after Dybel didn't quite pick that up.
I think they did, but I think maybe there wasn't maybe the same priorities and reception for that. I think especially,
Because it's also about relationship
yeah,
and connection with
President Bush was very engaged in you know, that
bringing
messaging.
people. Yeah. Okay. It's good to know, because we do care about, you know, Americans knowing about where the dollar, the tax that is
Yeah.
being used for that is actually going, because like looking at what has happened right now, people need to be informed what kind of difference this is.
Yeah.
I tell you, there's a lot of Americans that don't even know what PEPFAR is.
I know. I tell them I work for PEPFAR, and they look at me like, "What are you talking about?"
And yet that's like their W-2, 1099, right?
Yeah, I mean, like, I just spent like 30 years working on PEPFAR, you know, like 20 years.
You paying my salary, being on board and doing foreign service, but people have no idea. So, I mean, this is why I'm saying that, because there's a lot of opportunity there. Just so that, because it's good when you're giving something to know what kind of impact and change it has done.
Yeah, yeah.
Anyway, without digressing,
Yeah,
I'll
yeah.
just pause it right there. I just really wanted to find out
Yeah.
what you think could be done to make PEPFAR, whatever it is in the future, you know, funding model.
Yeah.
That might be there.
And
to
also, I think
support.
that, you know, there are opportunities, you know, with a lot more, you know, whether it's YouTube or, you know, social media, to maybe get messages across. I mean, like, if somebody making a recipe can get 1 million hits, why can't PEPFAR, you know?
Yeah, I got you. I'm with you right there. Okay, it's what they call third mission. You know, we usually do research for, you know, training and maybe university and writing books and all of that, but it's time also we move to that mission. Like, how does the research that we collect change? I mean, results to change,
Yes,
you
yes,
know,
yes.
be it policy, be it
Yes.
interventions, or even mindsets, you know.
Yes.
So it should not just be in monograph and nice books that are in our shelves, you know, as academia and researchers, but it's something to glean out of there that could make
Yeah.
life, the world better. So,
I mean, people shouldn't just think of the international environment during the Olympics,
yeah.
you know?
Yeah, there's a whole lot more that could be
Exactly.
done there. Yeah. So looking across your positions, I mean, you've also done some research and publishing. I mean, can you tell us about that? What do you think is very important to communicate out there based on your experience that you are writing about?
Yeah, so I actually, if you look at those publications for PEPFAR, not when I was doing research, a lot of those I'm like the senior author, or I'm not the first author.
Yeah.
And I'm there because I was the country director in the country, and there
I
was
see.
really other people who did the basic research and the writing. So,
Okay.
but I think the thing that what it was that maybe we had the idea in country, and they were able to follow through and get the data and write the paper.
I see.
But I think what's important, one of the reasons why we sometimes had to push our colleagues to write the papers was it was a good lesson learned.
Yeah.
And we needed to get that message out. But literature is not the way to get a message out. I mean, how did we get lessons learned out? It was through meetings, whether it was through COP meetings, whether it was through, PEPFAR had a lot of meetings. Okay, so all the people doing VMMC would get together and talk about it on a regular basis. All the people doing treatment, would get together and have meetings about that. And there was a lot of dialogue. In fact, one of the good things about PEPFAR was it created a family identity. You could be Nigeria, you could be Eswatini, you could be Ghana, but you were all PEPFAR country. You had all experienced many things. So you sometimes identified as a PEPFAR country, and also the partners were in the same country also. So if ICAP Ethiopia had a good project, you knew ICAP Eswatini would hear about it, and want to implement it. And it was also like, when we were at the meetings, in, COP meetings, people would hear, hey, I heard you guys got a great review from Ambassador Birx. What did you do? How did you get this? And then we would tell people, and they go, how did you do that? And there would be a lot of visits. Like
To learn.
To learn. Like in Ethiopia, we sent a lot of people to different places to learn different things. I sent people to Eswatini actually to learn some stuff. So if there was a successful, say, TB program in Kenya, they would do a study tour, and 5 or 6 countries would go to that PEPFAR program and see that. So I think that kind of programmatic exchange within not waiting for 5 years for publication, but really hearing about it at meetings, doing study tours, that was a much faster way to disseminate best practices.
Talking about that, I mean, you have worked in HIV/AIDS globally and in the headquarters. US has got its own challenges about HIV/AIDS. So what are some of the lessons that you have seen were very useful and effective in Africa that you think could be borrowed or learned to be implemented in the US? If there was an opportunity to do that.
So I think that maybe in Africa there was a better integration of clinical and community support. So there was a continuum between what you heard and did at the clinical level and the support you received at the community level, and the engagement of the community level in supporting people with the disease. It's been a long time since I've done domestic work, but when I didn't see that type of, outside of the gay community, I didn't see that type of support, So I think that was important.
The connection.
That connection.
Mm-hmm.
And I also think that the other thing was, there still is stigma, a lot of stigma in the United States around different populations. And maybe because I was working in more countries that had generalized epidemics, but I felt there wasn't the same level of population at the general stigma at the general population level. I don't think people really understand the disease as well here as they might, in Africa.
What could be the reason for that?
Not as many people know someone with HIV, maybe, or they have preconceived notions about how people acquired HIV.
Or just because there's access to healthcare, then it doesn't make people scared and
Yeah.
give it like the priority back in Africa, where people would know that at some point when you have it, you'll die. So if you don't want to die, go and take treatment.
True. I mean, there wasn't the same sense of vulnerability. I think so, but I think the community response is much stronger than it, at least it was than my experience here.
Because it shows partnership between the two. You bring the clinical expertise in the facility, in the hospital, but then people go back to the community. So if both are holding hands together, it's a much better intervention than if it's siloed.
But it's a long time since I've done any work domestically. So
Okay,
things
well, I
could be
mean,
different.
I'm saying this based on what you're saying about Africa. I'm just
Yeah.
paraphrasing to make it clear.
Yeah.
And just before we round up, you said a little bit about the nationals, the locally employed staff. I just want you to maybe describe for us how you would rate their contribution to PEPFAR project overall in all the countries you've been on the continent.
Yeah, so I think the thing to realize is that the bulk of the program staff, PEPFAR staff at the country level is the local staff. So there were, when I was in Eswatini, there were three Americans, and the rest of the staff was local staff. And they had the background and the experience. I mean, I'm not quite sure they needed us as much as we needed them. So I think, and their experience is very valuable. They understand the healthcare systems. They have the relationships with the government and with the partners. And they understand the context in which you're trying to do. That I have to say, in Ethiopia, it was just amazing. I think the technical competence was just outstanding. I mean, I think some of the most talented technical people I've ever met, United States versus anywhere, was in the local staff. They had really, I think PEPFAR did a good job internationally in attracting local staff that was highly qualified. People wanted to be part of the PEPFAR team. And I think that really added to the type of work we could do and the credibility that we had.
Okay. So, reflecting on your work with PEPFAR CDC, I mean, that elaborate career that you have had, how do you feel about it? How did it impact you personally and professionally to have had an opportunity to work within this arena?
So I think it's been a great honor and privilege to have been part of PEPFAR. It's been an amazing experience. I mean, if you're in infectious disease and working in HIV, to have the opportunity to work and have the resources and make a difference, that's the most satisfactory thing that can happen. And to feel like, your efforts made a difference, it's really been an amazing experience, and I'm humbled. I think the other thing is I have met some of the most amazing people. I don't think I would have ever had the opportunity to meet such talented, diverse people if I hadn't been part of PEPFAR. And I'm just humbled to have said I'm part of it.
Okay. So what do you think about, how has PEPFAR changed the way that you think about global health, international development in general? Is there anything unique
so I think
that experience?
Yeah, I think the thing that it made me realize is that so many things are possible with sufficient resources and sufficient commitment. So like being in Ethiopia and having seen more than HIV, I've dealt with Ebola and Marburg and, all these other diseases, cholera outbreaks. We can make a difference if we have sort of the resources and the right people there. And the world could be a much better place if that was our investment focus. So I think that was it was a, what's the word? It was a proof of concept that sufficient attention and investment can make a difference. In what was the first national security threat was HIV. That was declared as the first national security threat. So as we look as to what is going to be the ongoing national security threats, we should realize it's not something we should take lightly. It takes the right people and sufficient resources, and we can deal with it and make a difference.
Talking about enough resources, I mean, you have worked in global health for all this time, and we know that sufficient resources is not something we're going to have, like, given the situation right now. What are some of the things, like maybe during your own time, like contemplating about it, how could we make sure that resources are always there? I know like donor funding is one. Are there any other avenues or ways in which we could maintain like a pipeline of resources to continue these investments than to lose it when donor funding is pulled out?
Well, I think that, we didn't really engage the private sector maybe as much as we could have. And I don't really understand the private sector well enough to say what those opportunities are, but I think that if we look and say, where are there resources? There's the donor, there's the philanthropic groups, but there's also, the private sector. And then I also think that we should realize there's tremendous resources in these countries. So investment in these countries does not only mean that the outcomes will be just health outcomes. You have a workforce now in some of these countries in Africa you may not have had there not been PEPFAR investment. So...
Such as?
Okay, so let's say Eswatini. Mm-hmm. You would have had a whole generation of people that have died. South Africa, the same. Those people now are productive members of your society.
I see.
You have doctors, teachers that survived, So I think that kind of investment has an investment not only in health, but it led to an opportunity at the societal level for investment in multiple sectors.
I see. Okay, so very last questions. So, I mean, what do you think the global implication of this program, PEPFAR, what has been the global implication of it? Did it help us to shift our thinking, our approaches, our methodologies in terms of how global health has to happen?
Well, I think, as I said, it was a proof of concept in a way for global health.
Okay.
This sufficient investment can make a difference. I think the other thing it did was it made us realize that program can be effective. Because people used to think that, we needed a vaccine for everything. The first big investment is in a vaccine. Let's get a vaccine for this. But program is important. And I think the other thing that it taught us was that it's really important to have access to care and also to have community engagement in these issues. And that, it's not a matter of, it's a matter of like the community responding, not an outside force coming to respond. I think that's really important, that it's not WHO or CDC or someone coming in. It's really the Regional Health Bureau. It's really an investment in those groups is much better for a multi-disease or a multi-health response that's sustainable.
I think you've just wrapped that very nicely.
Thank you.
That's the end of my question.
Thank
Unless
you.
there's anything you want to say over and above that.
No, I just want to thank you very much for including me in this great project. And I'm very happy that these stories are being told, and I hope people hear them and understand what an amazing program it was and how lucky we all were to be part of it.
Well, thank you so much for your time, Carolyn.
Thank you.
For your insight. That was so important. I think there is a lot of new bulbs that popped out in my brain every time I talk to a different person. It's just a unique perspective. So thank you so much for your time, your indulgence, and having us in your beautiful home.
Thank you very much.
Thank you.
Bye-bye.